Hi Ninja Nerds, in this video we're going to talk about pre-eclampsia. If you like it, make sure you give it a thumbs up, comment down below, don't forget to subscribe, and then check out ninjanerd.org where we have all of our notes and illustrations for these lectures. Let's get started. So with pre-eclampsia, we are going to be talking about new onset gestational hypertension, okay? So it's new, it's not something that the patients had before, it's not chronic, it's not something that they've had previous before this pregnancy. So we're talking about a new onset of gestational hypertension that is present with proteinuria or the end organ dysfunction. And I have the or underlined in there because there are some new findings and new diagnoses criteria where it's now not proteinuria, but it is end organ dysfunction, or it's neither of them and it's just hypertension that has been new during this pregnancy after 20 weeks. So what I want you to understand is that whatever you're learning in school and whatever your institution uses as its diagnosis criteria, just make sure you're up to date and aware of it. But for the purposes of this lecture, we're going to be going with the new hypertension after 20 weeks into gestation, along with either proteinuria or end organ damage. So when we're talking about preeclampsia, we're going to be talking about hypertension that is new. So after the 20 weeks of gestation, we're going to have new hypertension, and it's defined as a systolic blood pressure that's greater than or equal to 140 and a diastolic that is greater than or equal to 90. So they can have either a systolic of 140 or greater or a diastolic of greater than or equal to 90. And then along with that, there can also be the proteinuria that's present, which is, we know, the proteins that are present within our urine, and that can indicate some type of damage to the kidneys. And then we can also have the end organ damage, which is our liver, kidney, eye, brain, heart, any type of organ that is crucial to life that we are going to be significantly worried about. So within this criteria, you're going to be thinking, a woman who is greater than 20 weeks gestation, who now all of a sudden is having some high blood pressure that is within those parameters or greater than those parameters, as well as having some protein in the urine or having some other issues going on that we might be thinking, this patient may have preeclampsia. But how does all this occur? How does preeclampsia, it just doesn't happen. One day you don't have high blood pressure, next day you do. It's a process over time, right? So what we're looking at here is the placenta, and we know within the placenta there's mom side and baby side. So we have baby side, we have mom side, right? So this is the portion that is attached right onto the uterine wall, and then this is our umbilical cord that is going up to baby. And within there we have the intervillous space right here, which is our gas exchange, our nutrient exchange, our blood exchanging area from mom to baby, and then from baby back to mom. And that's how we get blood circulation through to the fetus and back to mom. And there's certain types of certain anatomy features that are there, which are called spiral arteries. And these spiral arteries are located within the placenta. And what happens in a pregnancy, normally they will go from being their normal shape to dilation. It can be a significant dilation, 5 to 10 times. And what this is doing is to help give blood to baby, right? So we're trying to help baby grow, and what baby needs to grow is some nutrients, some oxygen supply, and some blood flow. So we're going to give baby more blood flow. So in that dilation, we are able to increase blood supply to our fetus. However, with preeclampsia, one of the presumed issues is that there is an abnormal dilation of these spiral arteries. So they become fibrotic, or they have some issues with being able to dilate, and because of that, we have an abnormal blood supply or a decreased blood supply to the fetus and to the placenta. And because of this, it can cause this cascade of problems that will ensue and show up as symptoms for mom. So let's talk about those now. All right, Ninja Nerds. So we're going to talk about what can happen with preeclampsia and how we have this decreased perfusion to the placenta can cause these problems with mom and baby. So we'll go through with baby. What happens when we have a decrease in this placental perfusion is we have a decreased blood supply to the fetus. And that can cause some issues with decreased intrauterine growth restriction, which baby can come out as a low birth weight, and or fetal demise, because the fetus is not getting the nutrients that it needs to thrive and therefore will become unviable. But then we can also have a lot of issues. Again, the placenta's got a mom side and baby side. So we talked about baby, but let's talk about mom's side, because mom is our main patient at this time as well. So we have this decrease of placental perfusion, and that can trigger an inflammatory response within mom, which will make mom's body release proteins. When these proteins are released, one of the biggest things that it does is it can affect our endothelial cells. And when we do have an infection, or not an infection, when we do have our endothelial cells damaged, we can actually have some issues that present and that we can see as signs and symptoms that we as nurses may say, this might be preeclampsia. So a patient might come in and have some problems with edema, right? They may have swelling in the hands, they may have swelling in the feet, and then other severe or concerning, as well as pulmonary edema, right? Some trouble with breathing, and then cerebral edema, or even edema within the eyes. So when we're thinking about this endothelial cells are damaged, which is increasing that permeability, we're going to have some swelling or edema, right? Another problem is that we could have some narrowing of the blood vessels. So when the blood vessels narrow, they're doing that because they're thinking, mom's having some trouble perfusing to placenta. Placenta's not getting enough blood flow. We're gonna help notch that up. And when our bodies do things to help us, they can also do things that hinder us. So one of those is that narrowing of the blood vessels. As the blood vessels narrow to help increase blood pressure, it can increase it too much where we start having some hypertension. We could also have the formation of the thrombi. Again, our body is trying to help us. We have some problems and damage within our endothelial cells. So it's saying, hey, I'll help you out here. I'll put some thrombi in there. But again, with that problem with the thrombi is they are restricting some blood flow. They are putting all of our platelets into an area of clot formation. And we can have some developments of HELLP syndrome, which is a subsequent issue of preeclampsia. And our HELLP syndrome is when we have hemolysis, we have elevated liver enzymes, and we have low platelets. And that is another topic we will talk about and focus in a whole nother video. And then the last thing is we can also have retention of sodium within the kidneys. So as we increase that retention, we can cause some damage to our kidneys, which will then be shown as proteinuria. So that will also be showing up with our patients. So this is just an overview of kind of what the pathophysiology looks like in a very small, very minute nutshell of that. But let's go in and talk about what are some of the risk factors, signs and symptoms of our patients, and how we are going to decide whether it is preeclampsia severe or not severe, or then moving into, unfortunately, eclampsia. All right, Ninja Nerds, let's go into some of the risk factors. So when we talk about preeclampsia, we're going to be talking about specifically some of these risk factors like prima gravida, or a patient that is pregnant for the first time. If they're pregnant for the first time, or if they have a multifetal gestation, those are generally the risk factors that can preclude preeclampsia. But there's also some others that are indicators of preeclampsia as well. Some of the big ones are obesity with a BMI that's greater than or equal to 30. If the maternal age of the patient is less than 18 or over 35, which is what we call advanced maternal age. If they did have hypertension, lupus, or diabetes, a history of preeclampsia with other pregnancies, or possibly in vitro fertilization. All of these can possibly indicate that our patient maybe has preeclampsia. But remember, preeclampsia is defined by certain determinations. So let's talk about those signs and symptoms. When we are looking at these patients, typically it's around 34 weeks where 90% of our patients are diagnosed. Remember, it's going to be that new onset of hypertension after 20 weeks of gestation. And the patients without severe symptoms are the patients that are having symptoms that are either asymptomatic, like they don't have any symptoms at all, but they just keep having high blood pressure. They also have possible headaches that are specifically aren't being treated with like Tylenol. They are just not getting better with any type of treatment that we can give them. They may have some right upper quadrant pain, some visual disturbances, edema. Again, we talked about the hands and the feet. And then that hypertension, which is the new onset of a systolic blood pressure greater than or equal to 140, or the diastolic blood pressure that is greater than or equal to 90. All of those are without severe symptoms, which is hopefully we can treat those symptoms and make our patient feel better and still have a normal pregnancy from there on out. However, there are some portions that are severe features, which is what we are delineating as an area that we're like, this patient may not go as far along in pregnancy as we want them to, and we don't want them to progress into some other issues like eclampsia or the HELLP syndrome. So when we talk about the severe symptoms, we're talking about a systolic blood pressure that's greater than 160, or a diastolic that's greater than or equal to 110. We're also looking at this when they are doing the blood pressures 2 times that are approximately 4 hours apart or more. It's not take the blood pressure, put it on the other arm, take the blood pressure, and oh, you have preeclampsia. It's more about a constant elevated blood pressure. Some other features that these patients may have is proteinuria and oliguria, the visual disturbances, specifically when it starts getting blurred. They have the pulmonary edema, which is that shortness of breath or the pink frothy sputum, and then the neurological changes that can be the confusion, the altered mental status, the dizziness. And we are getting to the point now where we're thinking, is this patient going from preeclampsia to eclampsia? And the change in that is just when a patient starts having some type of seizure activity. Specifically, it can evolve into tonic-clonic seizures. So when a patient does have eclampsia, that is when we have to start thinking, now we need to possibly have an early delivery and get this patient as stable as possible. So remember, with seizures can start different in every patient. And one of the big things that the NCLEX likes to use is like a tingling around the face or on the lips. So just keep that in mind as when you are assessing your patients, are you having any symptoms that you may not be aware of? Like, are you having tingling on your lips? Are you having tingling in your hands and feet? Things like that you want to ask them, because they could be having seizure activity that they aren't even aware about yet. But specifically, eclampsia will eventually evolve into that tonic-clonic seizure. So let's go into assessment and how we're going to assess our patients that we think may have preeclampsia that is progressing into eclampsia or HELLP syndrome. All right, so when we are assessing our patient, remember we said earlier that it's typically blood pressure, and it is 2 occasions that are 4 hours apart or more. So remember, we are looking at either those without severe features and severe features, but both of them will indicate that the patient does have preeclampsia. So remember, if it is 140 systolic or greater, or 90 diastolic or greater, that is considered our without severe preeclampsia. And then the severe preeclampsia, or the severe hypertension, is the 160 greater than or equal to 160 systolic and diastolic greater than or equal to 110. And then there are those 2 others that can be our criteria as well, the proteinuria or the end organ failure. So what we're looking at here is a patient with proteinuria. Patients may give away what they already have with them, going on with them without even knowing that they're saying to you. They may come in and just say, I don't know, I've been having these little bit of dizzy spells in my pee. I just noticed it's really weird. It's like foamy. And some of those are little indicators that you as a nurse will be like, that's interesting. So when we are testing for proteinuria, we can do the 24-hour urine collection, and then we're going to see that the protein is greater than or equal to 300 milligrams, or we may even do a dip stick, and that's going to be greater than 1. We also have the end organ failure. So the end organ failure is a little more broad in the sense that we are looking at some labs that are going on as well as their liver and kidney function. Because remember, when we talk about hypertension, a lot of times the kidneys are always involved, as we see here, but there also can be liver. We're thinking about the brain if there's altered mental and breathing as well. But when we're looking at especially the blood work, we're looking at the CBC, the platelets, and the red blood cells. Because if those are off in a certain way, then we could also progress to HELLP syndrome. So I know it's confusing. This video is on preeclampsia, but there is also evolutions of preeclampsia into HELLP syndrome or eclampsia. And one of the delineations for HELLP syndrome is that it's actually an acronym for what is going on with the patient. So that is hemolysis, elevated liver enzymes, and low platelets. And this can cause a whole nother issue with mom, especially through pregnancy. So this is going to be a whole nother video, so make sure you keep your eyes out for that. But it's a very specific area of patient care. But when we are assessing our patient, we're not only looking at just the checking off the boxes like, yes, they have hypertension, yes, they have this, yes, they have that. We want to see our patient as a whole. So remember, we're still looking for those other signs and symptoms that we talked about earlier, which is, where is the edema? Do we have any swelling? Are we having any other issues going on with our vision, with our mental status? Because we want to see our patient as a whole, because we are seeing our mom here not only as this patient, but we have a potential patient as well, which is baby. So we have to make sure we are keeping an eye on both. So let's go in to talk about what is going to be the treatment for a patient that possibly has preeclampsia, and what are we going to educate our patients on. All right, so let's talk about the treatment of preeclampsia. We've talked about how there's different delineations between the different types, this without severe, with severe, moving into eclampsia. So Without severe symptoms, typically the patient is able to deliver around 37 weeks 0 so that we are able to have a full-term baby, full-term pregnancy. However, if they do have those severe symptoms that are not being able to be controlled, we may want the patient to deliver around 34 weeks 0. And then if they are unstable, whether it's mom or baby, maternal or fetal, we may want to move into other areas as well, thinking about getting these patients stable as best as we can. Now, if the patient is moving into that eclampsia or right on the cusp and going into labor, because of preeclampsia can not only start in pregnancy, it can actually start after pregnancy. So if the patient is having some concerning signs, you may want to start the patient on magnesium sulfate before seizures even start. So that way we can hopefully prevent seizures from occurring, because we do not want our patient going into a tonic-clonic seizure and possibly having a fetal heart rate decrease and then have some other issues down the line. So they may do some prevention with the seizure precaution and giving them magnesium sulfate, or we may be able to just control hypertension. If the patient is having just this preeclampsia episodes and having some issues with the control of their blood pressure, we can give them some nifedipine, which is an oral antihypertensive to help them bring down their blood pressure. We may also give them, when they're in the hospital, an IV push of labetalol or hydralazine to help control the blood pressure, as well as giving them encardipine, a continuous IV, if they are being uncontrolled with those IV pushes, so we can have it a little more stabilized as well through a continuous drip. But the whole goal for stabilization with eclampsia is the stabilization, because this patient now is going into the seizures that we are not able to control as we would like to. So the biggest thing with eclampsia is our seizure precautions and our seizure education. So remember, you always want to mark the time. You want to make sure you're able to check on your patient. Airway management is very important, or a non-rebreather. If they do not have any type of oxygen supplement, you can give them a non-rebreather when they're in this. We must also give them anticonvulsives like the magnesium sulfate or any other medications that the patient or the doc deems needed for this patient, as well as possibly deliver once mom is stable and the seizures have stopped. So this is how we're possibly going to treat our patient. Again, this is a very narrow overview of what the care of a preeclamptic patient will look like, because again, we are possibly going into labor and then having the baby being delivered, as well as continuing on with the care, because this preeclampsia can progress and actually show up after delivery. But there is going to be some education for our patient. The biggest thing is that we want them to know how to take care of themselves and know the signs and symptoms of preeclampsia. So we want them to report to their healthcare provider any increase in the blood pressure. So if they're able to take their blood pressure at home, we are able to keep an eye on it and let them tell us when it is elevated, so we can hopefully get ahead of it before there's any other issues going on with them. The unrelieved headaches, we want to be able to tell them to tell us that as well, because that might be an indicator that it is preeclampsia is evolving. The abnormal abdominal pain, which could be right upper quadrant. Any abdominal pain, just always tell them to check in with their healthcare provider. That change in the neuro status, specifically the confusion, the altered mental status, anything like that. The ability to monitor the fetal kick count, and I have the kicks in quotations here because kicks can also be, it's not just the kick of the foot of the baby, it can also be like a flutter that they feel. It could be any type of movement they feel. The baby does a whole somersault in there as well. And remember, when we do monitor our fetal kick counts, there's a couple different ways the mom can count. You just want to make sure that they do it the same. So specifically, per policy at your facility, we usually tell them it's the same time each day. You're going to count the number of kicks in 1 hour, or you can also tell them just count up to 10 kicks, and whatever that time is, that's how many kicks you should be feeling. And they should be sitting or laying on their left side in order to get these counts. We want to make sure we're encouraging those rest periods and that they are laying in that lateral position when they are laying down flat, in order to offset so we're not having all that pressure on our inferior vena cava. And there are some complications with preeclampsia and eclampsia, and this also then goes into those complications with HELLP syndrome. So the complications can be HELLP, can be also stroke. We also have that preterm birth, like we talked about before, where we may just have to induce for delivery, or mom may give birth sooner than we would want to. And there's also that decrease in the birth weight, because we do have that gestational intrauterine hindrance on the growth of the baby. And there's also the placental abruption, where the placenta starts to pull away because it is not working properly, it's having too much hypertension within there, so we are then going to have that complication of an abruption of the placenta. So with that being said, I hope you liked this video, and as always, until next time.